Next, we have Dr. Shishir Verghese from VR surgeon from Amita Eye Care, Tiruvalla. He would be talking about the OCT biomarkers in VITREOMACULAR interface disorders. Over to you, Shishir.
Yeah, thank you, Dr. Basil, and for having me here, and KSOS for this opportunity. So we've been talking about biomarkers, but I would say that vision is also a very important biomarkers, and not just to go by the OCT. So I'll be talking on OCT biomarkers in VR interface disorders. So what is a VR interface disorder? It is an incomplete PVD. And then in some patients, due to an abnormally strong adherence of the posterior hyaloid face to the macula, we have these VR interface disorders which tend to crop up. And that's because of the anterior posterior traction exerted by the vitreous onto the macula. So incomplete PVD is the culprit here, which causes all these vitreomacular traction disorders. And it's been divided into 4 types: VMT, epiretinal membrane, lamellar macular hole, and then finally the full thickness macular hole. So this is a normal vitreomacular adhesion which you see in a lot of patients. It can be either focal. Focal means it will attach to a localized point, and when it's more than 1200 microns, you can have a broad vitreomacular adhesions. So here again, if the patient usually don't have any symptoms, and they will be completely asymptomatic, vision will be good, and no intervention is hence required. So based on this international VMT study group, they classified as vitreomacular adhesion and vitreomacular traction. I won't go into too much details of this. So what is VMT? So VMT is actually a complication of partial PVD. When the vitreous doesn't completely detach from the retinal surface and it's firmly adherent to the macula, that gives rise to vitreomacular traction. So vitreous is adherent in a broad dumbbell-shaped region, which at the region of the macula. So what are the symptoms? So there's a big discrepancy. What the OCT shows you will be totally different from the symptoms what the patient has. So if patients with extensive macular traction can present with an excellent visual acuity, and some VMT cases may suffer from acute visual loss with a small scotoma. So this is an example of a patient, 75-year-old male, 6 parts was the BCVA. This was VMT at initial presentation. Just kept under observation and told him close follow-up, but he came about after a year where his vision had dropped from 6.6 to 6.12, and then we see that there is a progression in the VMT with the formation of an outer retinal hole, which means at this point of time, because he is symptomatic, he probably requires surgery to prevent further progression. So the question arises, do all OCT VMT require treatment? The answer is no. Most cases of VMT syndrome, they have good vision and mild tolerable metamorphopsia and do not require treatment. However, it needs to be explained to the patient that follow-up is extremely important. So what are the indications for treatment? So here I would say not just the OCT, but the vision is the important biomarker. You should treat only if patient is symptomatic, disturbing metamorphopsia, or decreased vision, ERM, CME, or if it goes into a full thickness macular hole or a tractional lamellar hole. So we don't treat the OCT, we treat the vision. So this is an example of a symptomatic VMT, a broad VMT, attaching over onto the macula, especially at the fovea with the presence of cystoid edema. And here the patient was asymptomatic, and this is the post-op picture showing improvement in vision as well as on the OCT. So next is the epiretinal membrane. So epiretinal membrane is again divided into 4 stages. Again, all ERMs don't require treatment. So what are the few biomarkers in ERM? So this is a stage 1 ERM where you can see this hyperreflective membrane there, epiretinal membrane, but the foveal contour is normal and the foveal depression is normal. So this is stage 1. Then we have stage 2 where the foveal depression is lost and the stretching of the outer nuclear layer can be seen. And some patients even do have some cystoid spaces. So here again the vision can be good. It could be either 6.9, it could even be 6 parts. And based on the vision and the symptoms of the patient is only when you treat such a stage 2 epiretinal membrane. Now stage 3 ERM causes the disruption of the fovea there, and then you have something called as Eiffel or the ectopic inner foveal layer. So it's just here what happens, another new layer props up at the fovea. The fovea has only 4 retinal layers as compared to the rest of the retina which has 10 layers. So here an additional layer comes at the fovea due to the chronic traction by the epiretinal membrane, and we have something called as the ectopic inner foveal layer. So when you have an EIFL, that's a negative prognostic factor, which means if you do surgery, the vision may not improve. It will remain the same, but it may not improve further. And the other one is the cotton ball sign, which can happen, which is basically a round and fuzzy hyperreflective lesion at the interdigitation zone near the photoreceptor layer. It can, if this is present, it can predict decline in visual acuity with time. However, some patients do have a good visual acuity even when you have this biomarker, which is the cotton ball sign. And next is the stage 4 epiretinal membrane. So here there is absence of foveal pit, there is presence of ectopic inner foveal layer, and there is also disruption of the retinal architecture. And if you operate on such cases, around 70 to 80% of them won't improve vision, and they have worse post-op outcomes. So next, coming to macular pseudo-hole. So how to differentiate macular pseudo-hole is that the foveal tissue is not lost in a macular pseudo-hole. It's rather U-shaped, and that U-shape occurs due to a traction from epiretinal membrane on both sides. So there can be retinal thickening, and the fovea is usually steep with vertical edges are seen of the fovea. Then we have the tractional lamellar hole. Tractional lamellar hole is separation between the outer plexiform layer and the ONL, which creates a schisis-like appearance. So it's described on OCT as like a mustache-shaped appearance. And as the ellipsoid zone is intact here, most of the patients, they have good vision even in tractional lamellar holes, and they require to be on close follow-up. The degenerative lamellar hole is another one which has a large cavitation extending into the outer retinal layers there, and is described as a top hat appearance. And sometimes they can have a proliferation on top of the retina, which is called as a lamellar hole associated epiretinal proliferation. Sometimes degenerative lamellar holes are seen in diabetics too, and the visual outcomes post-surgery is relatively poor as compared to tractional holes. So next is the foveal crack sign. So foveal crack sign is usually like a vertical small line which is seen at the fovea. So it's a predictor of macular hole formation in those patients who have undergone past planar vitrectomy for rhegmatogenous retinal detachment. So if you're following up a patient who has undergone vitrectomy for retinal detachment, and on follow-up on OCT you see this, so it's probably an indicator that your case is going to go into a macular hole. So next, full thickness macular hole. So it's an anatomical defect in the fovea with interruption of all retinal layers from the ILM to the RPE. And when you go, and sometimes the operculum can be attached onto the surface, and sometimes it can be detached, bringing to a full thickness hole or a stage 4 full thickness macular hole. So there is macular hole staging, small, medium, large, and based on that you can grade the visual acuity post-surgery. So a few of the prognostic factors for macular hole. So it's good pre-operative factors, good intraoperative factors, and good post-operative factors. So if you look at the pre-operative factors, the most one in our clinics, due to a busy schedule, we only go by the size of the macular hole, that is the base diameter and the inner diameter. And we rarely look at the OCT indices which has been described. So few of the indices which we use are the macular hole index, the minimum hole diameter, the basal diameter, and the macular hole index, and the hole forming factors which were taught as postgraduates. So to take home message, so OCT and newer theories of PVD help in better understanding of vitreoretinal interface abnormalities. So patients with VMT with good vision can be observed, and ERM staging and its biomarkers help in predicting post-op outcomes. So other than the macular hole indices, presenting visual acuity is also an important predictor for post-operative visual improvement after macular hole surgery. So OCT, a good one, spectral domain, is a valuable tool, and if available should be offered to all patients undergoing cataract surgery to look for any vitreomacular traction disorders or syndromes. Thank you.
Thank you, Dr. Shishir.